I teach you a breathing exercise for relaxation purposes. You're gonna breathe in for the count of 4, hold for 2, out for 4, hold for 2. Do it together. 1, 2, 3, 4, 1, 2, 3. Better already? Okay. Let's do it. Okay, so today we're going to talk mostly about the general stuff, the background. That's part 1, anatomy, review of defense mechanisms in the respiratory system, and just basic overview of disease processes. Similar to my other lectures and other units, I'm very focused on like big picture concepts, make sure you understand how things work in the respiratory system. And then part 2 and 3 are going to be species-specific diseases broken down by small versus large, and some chickens if we have time. So quick review of the structure of the upper airway, pretty much from the nasal cavity to the upper part of the trachea, and histological components are here. So important points. You do have some stratified squamous epithelium. So thinking about like who lives here for cancer, squamous cell carcinoma is a possibility. Squamous there. And then as we progress down, we're going to get ciliated epithelium. So ciliated epithelium is special because there's certain bugs have a propensity to attack places that have cilia. They wish they were cilia. So we're going to talk about things like mycoplasma, Argosella, Bordetella. Those are the things that want to be cilia. So ciliated respiratory epithelium to be a target. And then obviously trachea, and we have some special structures that vary by species. The guttural pouch and horses is a big modification, but also the frontal sinuses, the paranasal sinuses, and the auditory tubes are all part of the respiratory system. So function of the upper airway is very important because when we get disease, it's going to cause dysfunction. So it's going to interfere with these 3 things. So main purpose of the upper airway is conduction of air. It also conditions the air for us. So it warms it, adds humidity. And it also is our first barrier to filtering out larger particles and potential pathogens. So the lung is pretty uniquely susceptible to injury because like your skin, it's pretty heavily exposed to the outside environment, but it doesn't have nearly the same defenses as your skin does. So there's a large aerogenous exposure. The human lung, 9,000 liters of air pass through your lung every single day, which is a really big number. So that's a very large exposure volume of air that you're sampling. You also have to worry about hematogenous exposure. The lungs get the entire blood supply. So there's almost 10% of your total volume of blood in your lungs at any one time. So they also get not just a huge air exposure, but a huge vascular exposure. So any insults that are going to come through the blood from lungs can be very susceptible. So defense mechanisms in the respiratory system are primarily trying to keep particles out. That's mostly the upper airway. And then if you do get particles in, you have to have some system to deal with them. So that's the lower airway after we bypass the upper filtration. Okay. So in the upper airway, your defenses are primarily mechanical. You have a larynx that opens and closes to keep things out. You have branching points all down your bronchial tree, and each one of those is a place where particles can filter out before they go to the next branch. You also have kind of chemical and physiological barriers, such as your resident microflora. They live in this mucus layer, and they're like a space occupying effect. So there's good and neutral bugs that live here. There's no space for bad bugs to move in because my normal microflora is taking up that space. Some of these guys also produce kind of antimicrobial substances because of the nature of microbial competition in communities. So they actually can have antibiotic effects towards more pathogenic organisms. You also have this mucus layer on top of your cilia. That's physical trapping of things like pathogens, dust particles, stuff like that. It also has a dilution effect. So if you breathe in a toxin or a pathogen, they won't be concentrated. They'll be kind of washed out and diluted by this mucus. which also contains antimicrobial substances such as immunoglobulins. And then finally, sneezing and coughing are another mechanical defense. So if you get any irritation, you can kind of try to expel that stuff as long as it's still in their upper airway. Major defense that starts in the upper airway, continues into the lower airway, is called the mucociliary escalator. And this is composed of a mucus layer on top of a liquid layer. The liquid layer sits on top of your cilia, and the cilia beat in a coordinated fashion to push everything towards the larynx. So what happens is, because they're embedded in this mucus matrix, they're essentially pushing the mucus upward. So it literally makes like an escalator. So everything is trying to go up towards your mouth. So we talked about disease resulting in dysfunction. So dysfunction of the upper airway will result in loss of those two major functions, which would be air conduction, so obstruction to airflow, and then loss of that filtration function, interference with cilia. Very important part about upper airway disease, since this is your defense tube against things coming into your lung. Upper airway disease predisposes you to lower airway disease. Super important. All right, so dysfunction in the nasal cavity. We can have obstruction by various things, or loss of filter function with loss of our cilia, or with loss of mechanical barriers. So backing up a little bit, kind of my general approach to lesions. First, we ask ourselves, is it normal or abnormal? We do our description. Where is it abnormal? What's abnormal about it? And then, pretty important for looking at specific tissues, has something been added to the tissue, or has something been lost from it? So is the tissue bigger than normal? Is it firm? Is it swollen? Do you see exudate or blood, or have you lost something? Is the tissue shrunken down, wrinkled, smaller than it's supposed to be? In the lung, we don't have much parenchyma, it's mostly air. So have we lost air, and that's made the lung smaller? And then lost tissue is often replaced with fibrosis. So loss of tissue goes along with those shrunken, firm, fibrotic lesions, as you all know. So rhinitis and sinusitis, a couple different flavors. Here are the associations with those flavors. It's like any other organ. Suppurative neutrophils, often bacterial. Ulcerative disease, ulcerative inflammatory lesions in the nasal cavity. And sinuses are often viral, so it's things like herpes, flu tongue, distemper virus. Kind of less specific, eosinophilic, often allergic, but can be parasitic as well. And then granulomatous, pretty common in dogs with sterile foreign bodies, so migrating grassons, stuff that gets sucked into their noses, especially in the long nose breeds. Fungal, and then as usual, higher bacteria, Actinomyces nocardia, mycobacterium, stuff like that will also cause granulomatous inflammation. Neoplasia, again, who lives here is the question. So remember, in the nasal cavity, we have stratified squamous, we have pseudostratified, we have ciliated epithelium. Epithelial tumors are going to be the most common in the nasal cavity, and they are often malignant. Here are the flavors. This is a weird one we talked about just briefly in neuro, this neuroepithelial carcinoma and physioneuroblastoma. This is not one, but this is the location where it would be, and it would kind of crawl through the one plate and often affect the brain. So that's specifically an olfactory neuroepithelium. And then you can have our mesenchymal friends here invading from anywhere in the nasal cavity. Lots of cartilage, lots of bone in there. And then lymphoma does whatever it wants. It can go anywhere. This is lymphoma in a cat, causing an ulcerative lesion on the nose. This is an enzootic nasal tumor in sheep. It's an adenocarcinoma. You can see it's expanding and pretty much obliterating the cribriform plates, pushing the turbinates forward. It's not quite into the brain, but we're getting close. The breath away. And then this, I don't remember what this is, but it's very solid, and it's necrotic and cavitating in the middle. So this is probably a carcinoma. Of course, appears to be. Choanal atresia. So this is a mechanical congenital obstruction of flow. So your choana are the openings between, you have a great for so rostral choana is your external opening, and then you have an internal choana, which is the opening between your nasal cavity and your nasal pharynx. So this is a normal animal. You can see there's an opening right here, goes from the nasal cavity to the nasal pharynx back here. This little guy does not have a properly formed nasal cavity. He has no internal choana. So here's his nasal cavity. Here's his nasal pharynx, oral pharynx, and you can clearly see there is zero communication. Atresia means it's not there. It's very small, almost too small to see. This can be unilateral or bilateral. Really, really common in camelids, but can be seen sporadically in other species. And these guys will present usually pretty young with signs of upper airway obstruction, so exercise intolerance, sometimes aspiration. Some other random causes of nasal obstruction: inflammatory polyps are extremely common in cats. They're usually either in the eustachian tubes or in the nasopharynx, sometimes in the ear. But these can get quite large and cause obstruction, especially if they protrude into the larynx. These are non-neoplastic. They're just thought to be stimulated by chronic antigen stimulation, and also potentially part of this weirdo eosinophilic granuloma complex that cats get. You can also have nasal parasites. Aren't they cute? I used to think these were eyes, but I'm pretty sure now this is actually its butt. So this picture is less cute than I thought it was. But here's a little nasal bod hanging out in the turbinates of the sheep. Here's another one down here, and he's a little lost back in the pharynx. This isn't the nasal cavity. And again, foreign material, pretty common in dogs, but you can see it in any creature. Nasal amyloidosis is kind of a weird one. So that's this guy down here. This is a horse thing, and they present as these very large, firm, smooth, pink, tan nodules, usually in the turbinates. Amyloidosis usually associated with chronic antigenic stimulation. Not sure why it's a horse thing, but stupid horses. And then another stupid horse thing, they get ethmoid hematoma. So the ethmoid terminates right by the cribriform plate. Those can bleed and form like these big, dangly, gross hematomas, and they can actually hang down into the nasal cavity, obstruct their flow. Okay, so here's Voodoo. You guys were asking about him. He's still in the presentation because he was a cleft palate baby. This is him at birth. I'm very happy they did not euthanize him. So my main point about this, you could read all the medical cleft palate stuff, but we don't learn about these guys in vet school. The dogma is just kind of, oh, it's a cleft palate. It's going to be hard to raise. It's going to aspirate. Might have other defects. You should just euthanize them. So that was kind of all the advice that we received. And I was like, but I would like to, take care of him and surgically fix his palate. And, what do I do? And vets didn't know what to tell me. So these guys do exist. They're out there. Please don't euthanize them all. Some of them are fine. Some of them do have other defects. Buddha was fine until about 6 months. And then he presented with this weird congenital neuromuscular things. But he had a great, almost 2 years. I'm glad he lived. I'm glad they didn't euthanize him. So learn to take care of these guys. They can be very rewarding. His palate closed almost completely by the time of surgery. So surgery is usually 8 or 9 months. And by then it had almost completely closed. We were thinking about maybe he doesn't even need surgery anymore. The thing you do have to worry about with these guys is aspiration very early on. So they cannot nurse because they can't generate suction. So you have to remove them from the mother and you have to tube feed them. They're a big aspiration risk, but once you get them weaned, risk goes way down. And then the big thing you have to deal with is potentially chronic recurring nasal infections. So rhinitis, sinusitis, because they haven't open communicate with their nasty mouth. So he got 3 or 4 rounds of broad spectrum antibiotics. Every once in a while, he got a little sniffly. But that's their big problem once they reach weaning. They are also at risk for other midline defects. So do you guys remember some of those? We talked about them in neural tube defects. So yeah, spina bifida, not so much, but the more minor midline defects, so hypospadia, PPDH, peritoneal, pericardial, diaphragmatic hernia, things like that. Okay, so dysfunction of the larynx, again, obstruction, loss of filter function are going to be the two big things. Laryngeal edema is a very common cause of laryngeal obstruction. It has many causes. Probably most commonly that we see here in the lab is severe dyspnea. So animals with a history of severe respiratory distress, they're breathing very hard. That's actually can be traumatic to the larynx. So you can have swelling, and then that causes further obstruction, and then more dyspnea. So it's kind of a self-feeding cycle. Local trauma is one we see a lot in large animals. So improper intubation or use of a ball gun can cause trauma to the larynx with lots of swelling. Surgery in the neck, so things that don't involve the larynx directly, but maybe you're doing thyroid surgery in a dog or cat, and the regional swelling can grow to involve the larynx. And then systemic disease, so anything that causes whole body edema. Laryngitis in animals is often either ulcerative or fibrinonecrotic. And this can be a progression. So you can start with an ulcer and then it becomes covered in a lack of fibrin and necrotic debris. It becomes fibrinonecrotic. I remember last year we spent a lot of time talking about this diphtheritic membrane. So what this is, I'm just going to skip right to the chase and draw it so everybody understands it. So here's your mucosa, right? You have an ulcer in your mucosa. An ulcer is where you've lost epithelium down to at least the basement membrane or more. So your epithelium gone. Your epithelium gone, and you have exposure of whatever's down here. You've got leakage of fluid coming out, things that ought not to be exposed to the environment, right? So plasma proteins, fibrin, you get a bunch of little fibrin strings covering this membrane. You're still ulcerating, so you've got dead cells in here. And pretty soon, now remember how fibrin is like kind of stringy and sticky and it just kind of like sticks to things? You've got almost a membrane here formed of fibrin and dead stuff. You could literally peel this off the tissue in a chunk and see the ulcer underneath. I know, gross, but so good. So this is a fibrinonecrotic membrane or a diphtheritic membrane. GI does this all the time.
Okay, so yeah, they had this, and I think it was associated with bacterial infection, but is it not always associated with bacteria?
It's associated with ulcerative and necrotic infections. So it depends where you are. In the GI, salmonella does this because it's very necrotizing. So anything that kills that epithelium and exposes the underlying tissue is going to likely cause a fibrinonecrotic membrane. So in the respiratory system, it's often viral. So you get a viral ulcer and then often a secondary bacterial component. So it's kind of both. But in the respiratory system, if you see ulcerative lesions, your first thought should be viral. In the GI, lots of different things cause fibrinonecrotic. So everybody understand what a diphtheritic membrane is. Peel-offable mat of fibrin and goop covering an ulcer. Trauma, so literally anything that causes an ulcer, you can have a traumatic ulcer, and that can get covered by a necrotic membrane with secondary infection. Yeah, if this gets really bad, you can slough out entire casts of your mucosa. Yeah. There's a really great medical history museum in Philadelphia. If anybody ever gets to Philly, been there? Yeah, the Mutter Museum. It's awesome. So if you go in the room with all the jars, there are literal casts of human gut mucosa that people just out. It's like that's the most horrifying thing, but it's fantastic. Go there, everybody. They have a giant colon. That's their main draw. It's like bigger than my arms, and they like removed it and dried it and like stuffed it with hay, and it's like in this huge display case. You get postcards of it. Anyway, the respiratory system. Okay, So fibrinonecrotic lesions, often viral, associated with specific agents in specific species. So ILT in chickens and turkeys, aka fowl diphtheria, calf diphtheria, right here, Fusobacterium necrophorum is the associated agent with that. So that's bacterial. So there are associations, but there are a lot of things that can cause ulcerative lesions, and if you get an ulcer, you will get fibrinonecrotic inflammation. Obstruction of the larynx can be anatomic, inflammatory, plastic. Laryngeal neoplasia is pretty uncommon. There is a tumor of skeletal muscle that occurs on the tongue or larynx in dogs, but even that's pretty rare. And you can get invasion of thyroid carcinoma into the larynx. Also pretty rare. Probably the most common one we see as a cause of death on the floor for anatomic obstruction is BOAs, so brachycephalic obstructive airway syndrome, elongated soft palate, stenotic narrows, epiglottis, things like that. Very, very common cause of upper airway obstruction. And then this is kind of a special case. So loss of filter function, especially when it's neuromuscular, can also result in a degree of obstruction. So this one has a little bit of overlap because your larynx is not working, and part of the function of your larynx is to keep things out. So you can't open your larynx all the way. You're also going to get obstruction. So causes roars in equines and in voodoo. So this is not voodoo, but this is what his trichoaretinoideus dorsalis muscle looked like, where you have unilateral atrophy. This white pale stuff is atrophied muscle. Here's the normal on the right side. It should be nice and dark and meaty, like a steak. So this is usually due to denervation of that muscle. Laryngeal paralysis or LARPAR in dogs. Again, degenerative neuromuscular disease, often in older dogs. In dogs, it's often bilateral. Equines, it's often unilateral. Any cause of neuritis, so rabies can cause LARPAR. So altered voice is a potential sign of rabies. And then some systemic causes that cause neuromuscular weakness.
Question.
Yeah.
Might have missed it, but for unilateral, it specifies that it's most likely on the left. Why is that?
It is because of the anatomy of the left recurrent laryngeal nerve. It takes that long path down. I can't remember where it goes, but the right one goes right there. The left one goes okay on there. So it's longer. It's more susceptible to degeneration. There's more of it. Didn't answer that well. Does that make sense? Kind of, yeah.